for the next few hours, we'll talk more about sickle cell anemia. In high-resource countries, over 95% of children with sickle cell anemia live into adulthood, whereas in low-resource countries, 90 to 95%, as David said, die before the age of 5, either from complications of the disease or from common infectious diseases such as pneumonia, diarrhea, malaria. So in MSF, we have been seeing, in the field, quite a lot of projects and field staff are facing the challenge of how to manage children with sickle cell anemia who are presenting to the hospitals and to the clinics. And mostly, the care has been mostly supportive. So the question today is, what more can we do? And what simple interventions can we feasibly put in place to decrease mortality and to decrease the suffering for these children? Pass it over to you.
Thank you very much, Isabel. I'm sorry for my English. It's not so good. Before I want to congratulate our young friend, David Issam, for his testimony. It's very good and very strong. I'm very glad today to be here and to co-chair this session on sickle cell disease with Isabel. And I thanks MSF who give me the opportunity to be here today. I come from Senegal, which is very far from Sweden, in West Africa. And they give me the opportunity to share some experiences, to learn a lot with someone here, and to be here for a very big, an important problem of public health, like sickle cell disease in our countries, in West Africa and in Central Africa. And to talk about this, we have three big experts we are going to introduce now. And the first expert I'm going to introduce is Mariane de Montalembert, excuse me for the pronunciation, which is a professor of Paediatric in Dakar, Enfants, Malades. And she's following all the patients with sickle cell anemia. And she has a very strong experience on this disease. Mariane, you have the microphone. Thank
you. Sorry, where is the... Okay. First, I would like to thank the organizers, and I'm very honored to be with you. The second point is that it is really difficult to make a talk after you, David, because it was fantastic, and I will try to do it. Sickle cell disease, as you know, here is the map, and you see that the mutation appeared several thousand years ago in Africa, where it was selected by a relative protection against malaria, and it is related to the presence of hemoglobin S, and the most frequent presentation is hemoglobin SS. It is a lifelong disease. This is okay. So at the very beginning, there is only sickling, and the baby, when they sickle, they may have pain, and the pain, as said David, is the hallmark of the disease. You have pain all time, all your life. And the sickling introduces the dysfunction of the spleen. If it works not enough, you have infections, here osteomyelitis, pneumonia, and if it works too much, you have a splenic sequestration which kills a patient within very few hours. But after people are getting older and there is a settlement of a disease of the endothelium which gives rise to settled organ failures with strokes, heart disease, renal failures. When they are pregnant, women have a 6-fold increase of dying from sickle cell disease. Globally, it was published recently. The life expectancy has dramatically increased, and I have noted some steps which for me were extremely important. And these are the dates where these procedures were implemented first: penicillin, neonatal screening, hydroxycarbamide and transcranial Doppler, and we are going to see whether these measures can be extended to Africa. But globally, if you consider some of the studies are old, but for instance in Kenya, here you can see there are a number of patients with sickle cell disease, less than 2 years old, but when they are growing, there is a dramatic number of deaths related to sickle cell disease. So the key points, I think, which have to be discussed are listed here: diagnosis, infection, pain, anemia, hydroxyurea. And diagnosis, it's not difficult. It's very easy to make a diagnosis of sickle cell disease. This slide was given to me by a good friend of Isaac and me, Professor Jacques Illion. And you have all these tools that you can perform to perform the diagnosis of sickle cell disease. And when you want to make a neonatal screening, most countries, they use heel stick, and then they use isoelectric focusing and HPLC. But all these techniques allow to perform career screening, genetic counseling. Of course, we won't discuss about prenatal diagnosis or pre-implementation diagnosis because they are not affordable at all in Africa. And the point is that it's easy to make this diagram, but I have now 25 years of experience in treating patients with sickle cell disease coming from Africa. And in my experience, the families, even in very high resource families, are not informed that the tests are available, even if they can pay for them. But most of all, they're not convinced of their usefulness, and most of all, they are not willing to perform the test because this explanation is not believed. And in almost all cases, even in couples with very high level of education, it is believed that the disease is transmitted only by the mother. And if the child is having a sickle cell disease, it is the mother which is guilty. And if you introduce these tests I have listed just before, without giving the explanation, the mothers will be left by the fathers. And in all the papers you can read, 40% of mothers are alone because the husband has said, well, the disease has been transmitted by my wife. And if you give the test without a very, very careful explanation, it will be a disaster for the women. And I say really a disaster, and they will be completely stigmatized. And to give the test is not enough. You have to give the explanation, and it takes time. These tests I show you are costly, but you have very cheap tests. And this is the last one, the sickle scan. Perhaps, Isaac, you are going to talk about a sickle scan. So it is quick. It is cheap, small blood sample via finger sticks. It is not perfect because it does not distinguish between normal hemoglobin and some rare hemoglobin disorders, but it could be implemented everywhere, not expensive and highly useful. But do not give the text without explanation, I repeat. Otherwise, it will be a great problem for the women. And it works. When you use neonatal screening, you have no more deaths from pneumococcal sepsis, strokes, or acute splenic sequestration. But when you look at this map, which was published by Fred Peel, it is a projection of the hotspot, I should say, of sickle cell disease. And you have Central Africa, Nigeria, and India. And in fact, when you look at the places in the world where there is neonatal screening, it is not in these in these countries. There are some experiments in those countries, but there is no neonatal screening. When there is neonatal screening, in fact, there is an experience in Angola. And the team provided, in fact, isoelectric focusing plus confirmation. They provided Prevnar 13, daily penicillin, and prophylaxis against malaria. And on a 2-year period, they had 500 sickle cell disease patients. And the first point is that they missed 1/2 of this patient because they could not localize the patient. First failure, you diagnose, but you lose the family. And the second point is that in those they successfully contacted, they were, some patients were mistakes, some patients died before being contacted, and there is a fraction of patients who do not want to be treated, who refuse the diagnosis. And after, also, a small population who refuses the care, and so giving care is not enough, you have to give explanation. What is here is the cost. It was published in September, so you have a cost which I think can be debatable. And here in the same paper, this is the cost effectiveness ratio, and the higher is the diameter, the greater is the diameter, and it shows the very that in some regions of the world it is really cost effective. Second point is infection. They are frequent, and they are the first cause of death in children in Africa. They are fulminant, and they are related mostly to the fact that there is a spleen dysfunction, but it is surely not the single cause. There are other causes for infection. And most of all, they are related to pneumococcus, and they are responsible for meningitis, septicemia, and so other. The point I would like to emphasize is that they are life-threatening, and when you have the first symptoms, fever, pallor, you have less than 3 hours to provide transfusion, antibiotics, or morphine in case of pain. Otherwise, the patient is dead. And it depends, of course, of the many things. You need to have antibiotics, but you need also to have roads so that the child comes to the emergency care unit. And you need also to have education of mothers and education of first care providers. You have also 3 hours. So prevention of infection is based on daily penicillin, of course, immunization, and I insist, education of parents and first-line physicians. Fever higher than a 38.5 in a child younger than 3 necessitates probabilistic antibiotherapy targeting pneumococcus. The next key point is pain, and David explained us pain. It is really the hallmark of the disease, and this painting was made by a patient who has sickle cell disease, and it represents what is pain. Opioids. David spoke of opioids, but in Africa there are no opioids for sickle cell disease. It may be complicated by acute chest syndrome, and it may be responsible for death. Need for psychological support. More you are painful, more you are painful because you fear the pain. And hydroxycarbamide is highly discussed. Anemia. We have talked this morning about hemoglobin level, and in fact, in sickle cell disease, hemoglobin level means several things. First, what is the goal of transfusion? It's not only to correct hemoglobin level in order to restore oxygen distribution to tissues, but it be also when you have a blockage in the vessel, you will bring new deformable red cells just to restore the blood flow. Whatever the hemoglobin level is, only to bring deformable red cells, which can be performed using either acute simple transfusion or exchange transfusion. Globally, 90% of patients, not children, 90% of patients in sickle cell disease have been transfused. What are the causes for acute anemia? Of course, acute spleen sequestration and parvovirus B19, but also malaria. In Congo, the first cause for transfusion is malaria in sickle cell disease patients. Just an example of what is acute splenic sequestration. Here is this is a normal red cell, and he has to go through venous sinus, and he has a size of 7, and this slit is 0.5, and he has to transform into a spaghetti to be able to go through this tiny slit. And when he is sickled, he can't, and therefore the red cell remains within the spleen, and the child is dead. Transfusion complications, of course, are alloimmunization. We won't talk about iron overload, but because there is not enough blood in Africa to get iron overload. Central venous catheter complication, we're not going to talk about, and infections. Alloimmunization in Europe and United States is the biggest problem about transfusion, but the point is that it is also a great problem in Africa because there is no systematic looking for alloantibodies. And almost whenever I receive a child coming from Africa, he has already acquired several alloantibodies, and it is a mess to find a proper blood to transfuse him. So it is not exclusively a European and American problem, the discrepancy between the blood groups. It is also an African problem because they do not look for alloantibodies, and it is a regular cause for death. What about infections? This is an old publication because now it has 6 years old, but it was a percentage of the nation not screened in different countries in sub-Saharan Africa, you can see here. And just look at in France, for instance, the risk of getting HIV infected is 1 out of 3 million of the nation. It is 1,000-fold more in sub-Saharan Africa. And when you look at this map, you can think it is a map of the presence of sickle cell disease, not at all. It is a map of countries where there is no blood. It is exactly the same one. There is no blood donation in these countries. Another burden of sickle cell disease is stroke. Either you can get overt stroke, which affects mostly, here is the incidence in patients. You can have strokes, not infarcts, but hemorrhagic strokes, because you have those collaterals which are called moya, and there is a rupture and you may die. And also you can have those, here it's not very clear, you can have those little brilliant points which are silent infarcts, which are responsible for cognitive impairment. We can screen for that. We can screen for that using a completely harmless tool, which is transcranial Doppler, which is not expensive, but 600 euros. You can use, when you have money, MRI. And it works. Here it is a normal vessel, and here is a stenosis, and you can see clearly the difference of velocities, and it's very easy to do it and to screen for stenosis. If you find a stenosis, if you find a stenosis, there are several levels of treatment. After a first stroke, you use transfusion, or you cure the disease using bone marrow transplant. And if you have no transfusion, you can use hydroxycarbamide. In fact, it depends on the step of the severity of the disease. At the very initial step, hydroxycarbamide is enough. But this is an autopsic data 40 years ago, and here is a vessel, and this is hyperplasia of intima. And this is the place which remains to the sickled red cells to go through to bring oxygen to the brain, which is very tiny. And this is moya. And at this level of severity, hydroxyurea does not work. Last point, hydroxyurea, it works. It works in infants, it works in adults to reduce pain, acute chest syndrome, need for transfusion. Effects on survival are less clear. It depends on the increase of fetal hemoglobin, but globally, here in this publication, it was shown to increase survival, and these papers, it's debated. You have different ways to get hydroxyurea. In the United States, it is licensed for adults as drugs, 200, 300, 400. In Europe, it is licensed as Sickle in children and in adults. Long-term safety data are good concerning growth, genotoxicity, teratogenicity. There is a point about malignancies because to be sure that there are no long-term side effects, you'll need many people with long hydroxyurea exposure, and we do not have so far enough patients. The problem is about consequences on fertility. And here is the problem. For women, there is no problem. There is absolutely no consequence on fertility. Sickle cell disease, when you are highly painful, decreases sperm count and motility if you are highly painful regularly. Hydroxyurea decreases sperm count. Whether this hypofertility resolves after stopping the treatment is not known, especially when the drug is given in very young children and for a very long period of time. I should say that in all cases, survival is the priority, and you need to be alive to have a child. In France, we inform families about those uncertainties, and we propose storage of frozen sperm. In fact, there are different options. In the United States, they propose to give hydroxyurea to everyone. Everyone. In France, we propose, and in Europe, in Belgium and Europe, we propose to select indications, and this is a list of indications. More or less, it makes, in my clinics, I have 60% of my patients receiving hydroxyurea. And the problem is, first, do not harm. And there are uncertainties, and these are the trials which are developed by Russell Ware, most of all, in Africa, to see what is the tolerance of sickle cell, of hydroxyurea in sickle cell disease in Africa. And there is a concern about malaria. Does hydroxyurea has an influence on the occurrence of malaria? Cure is given by bone marrow transplant, but not feasible in Africa. Education remains the most important point in my opinion, and we have created this association. We have all these leaflets which are given to you. If you want to get them for free, you just make a link. And we have a lot of leaflets with drawings. We have created games, a lot of games, which are also, we can give you those games. And considering our initial aim, I think that we have 3 levels of intervention. First level, you can do them everywhere. It's have very quickly trained health providers, not doctors, health providers, just to look at education, provide vaccine, look at the growth curves, check baseline hemoglobin level, and treat mild infections and moderate pain. After, you need to have several proximity hospitals able to take care of anemia, fever, severe pain by providing, for instance, transfusion, antibiotic therapy, and morphine, and performing elementary tests. And you do not need to have several expertise centers. Very few expertise centers are needed in the country. Some references. And this is my last slide. I would like to say I joined these children. It was a meeting in Uganda in June, and they're asking for more money to sickle cell disease, for more intervention. And I would like to conclude by telling that it's not only penicillin and immunization, but also teaching, which are highly needed.
Thank you very much, Mariane, for this presentation, which is very nice and complete. Before we move to the second presentation, we are going to take some questions. First question.
Thank you, Mariane. Just can you give us the site, the website of Offset?
Yes, of course. I will write it. I've always problem with English. So it is created by the French Health Agency. I receive money every year, and I've created educational program. And I would like to have e-patients. If you see me.
Okay. Another question?
I have one question.
Okay.
Here. I want to ask, do you do prophylactic exchange transfusions before, like regularly, every month or something with your patients?
Yes, in some cases. For instance, in my clinics there are 700 children with sickle cell disease, and 80% for them are coming directly from Africa. And we have 50 children who are monthly transfused. Every day we have 5 exchange transfusions. They are mostly in 2 main indications. Failures of hydroxyurea. It may happen. Hydroxyurea is a miracle for young children, but is no more a miracle for adolescents. So when it fails, we give exchange transfusion. And then we have strokes. We have almost no more strokes in children now since we have implemented transcranial Doppler. But we have children coming from places where there are no transcranial Doppler.
Okay, last question. However, we have a general discussion at the end of all the presentations. We take on last questions, then I give to Isabel to introduce the another one. Last question.
I have a question on the painkillers. You said that there was no morphine in most of African countries. What are the alternatives?
I think that my colleagues from Africa will answer better than me to this question.
Okay. The latest, yeah. Okay.
My question is just relating to the Sickle scan. Sorry. So my question is just relating to the Sickle scan, the sensitivity and specificity of that.
I think Isaac, you are going to address this point.
Okay.
He's going to talk about Sickle scan.
Thank you.
Okay. Thank you, Mariane.
Thank you.
Okay.